Hello, everybody. Good afternoon. This is Dr. Pantha Rezaeian. I'm a family medicine and clinical lipidologist at Torrance Memorial, Cedars-Sinai. So I'm so glad to have the opportunity to speak with you guys here. And then we will have a very interesting topic, which is you versus cancer. So as you know, the cancer is definitely one of the most important health topics that we all need to start preventing and being kind of more proactive as far as finding it early enough before getting to the advanced stages. So the question is, and actually one of my patients today asked me, Dr. Rezaeian, what's happened? My friend said that my husband went to the doctor 3 months ago, and the doctor told everything is good with you, your blood test is good, and then after 4 months, the husband has been diagnosed with stage 4 cancer. How did it happen? So the doctor did not do the job. And I asked what was the reason that the husband went to the doctor. He got a cold. Okay. When was the last time that patient went to the doctor for annual physical or, the checking up annual wellness? He never went there. Okay, so the question is how we can have opportunity to check our patient when they're not coming to see us for annual wellness, which has been designed for a screening, for all those preventive measures. Just remember, the word of screening referred to all those measurements we are using to early detect the cancer or different important chronic disease in the asymptomatic patient. So it means the patient at some certain age, some certain conditions, they need to go and see the doctor, and based on their condition and age, we will run some tests for them. For example, usually for the people that they do not have a family history of colon cancer, at age of 45, we will run the colon cancer screening. There is a different methods, but we need to do that on the asymptomatic patient. So if the patient comes to see a doctor and has the abdominal pain, that would be totally different approach. Same thing about the breast cancer, same thing about the cervical cancer. So the question is there all the cancer can be prevented? Is there a screening for all different cancers? No. And the reason that we do not have the screening for every single cancer in the world, it depends on the prevalence of the cancer. There is, the committee, which they call it USPS task force, which run lots of population-based study, and based on the, the burden of the disease, as far as how much they need to pay for each single conditions, and then the prevalence of that, they will come up with a specific screening plan. So for example, for some conditions like pancreatic cancer, we do not have an age-specific screening, but we have it for colon cancer. Why? Because colon cancer is very prevalent. And then by doing the screening, which usually covered by insurance, technically we can prevent very many of the patients from getting that common conditions. Same thing about the breast cancer, same thing about the cervical cancer. My point is, even though we do not have the screening for all the cancer in the world, but by you going to see your doctor for your annual wellness, your annual physical, so it means that you do not have any problem, but by going to see your doctor once a year with the a preventative appointment, which is usually 30 minutes, you will talk with your doctor about all those screening can detect many common type of cancer and chronic condition and prevent very catastrophic events later on. So you cannot believe how many of the stage 4, stage 3 cancer we can see that could be prevented if the patient was adherent to going and see the doctor on a regular basis for preventative, not when they have a cold or cough. So my suggestion and recommendation for everybody is, no matter how healthy you are, and especially when you have absolute no symptoms, make sure you go to see your primary care doctor for the preventative, which is the opportunity for you and your doctor to go based on your age-specific guidelines for many of the cancer prevention and early detection. And by saying that, I'm going to introduce 4 of very great providers and physicians on our committee, Dr. Ali Jones, Dr. Horodner, Dr. Bhayani, and nutritionist Rika. So they are going to speak about the cancer, how they can prevent, and then how they can treat. So we'll start with Dr. Rashaan Ali Jones. She's one of my dear friends, of course, but also Dr. Ali Jones completed her general surgery residency program at Mount Sinai Medical Center in New York City and joined the Association of the South Bay Surgeons in 2008. Dr. Ali Jones focused on delivering personalized and compassionate care to her patients. A native of the South Bay, she especially enjoyed being able to serve our community. Dr. Ali Jones performs all aspects of the general surgery with a special interest in the treatment of the benign and malignant condition of the breast, advanced laparoscopic and colorectal surgery. Dr. Ali Jones specialized in the breast conservation therapy, which is lumpectomy, skin and nipple sparing mastectomies, and SLN biopsy, and partial breast radiation and breast radiation catheter placement. Dr. Ali Jones is the member of the American Society of Breast Surgeons and a fellow of the American College of Surgeons. Dr. Ali Jones has served as a chair of the general surgery at Torrance Memorial Medical Center since 2011. Dr. Rashaan Ali Jones is a specialist in the general surgery, breast surgery, and advanced laparoscopic surgery. Some of many procedures and diseases that Dr. Ali Jones treats include the abscess, appendicitis, biopsy, breast surgery, cancer, colon, cyst, gallbladder surgery, GI surgeries, hernia repair, lipoma, mass, melanoma, myopathy, and radio-guided surgery, and sentinel lymph node mapping. Please help me welcome Dr. Ali Jones.
Hi, good evening, everyone. Thank you so much for spending your evening with us and hearing about some important topics in cancer screening and prevention. As she mentioned, I am the co-director of the breast cancer surgery program at the Hunt Cancer Institute, a position I've held for the last several years. I've been in the South Bay for the past 16 years doing surgery, breast and general surgery. And again, I want to talk about breast cancer screening and prevention and a little bit about some nuances with breast surgery and breast cancer, okay? So first, I want to orient everyone with the facts about breast cancer. So as was mentioned earlier, female breast cancer is one of the leading causes of death in the United States. In the US, women are diagnosed with breast cancer more often than any other cancer, excluding skin cancer. And you can see the statistic, it is quite stark, but over 300,000 women in the United States will be diagnosed with breast cancer per year, and over 56,000 women will be diagnosed with in situ or stage 0 type breast cancer. 16% of newly diagnosed patients will be under the age of 50. And although breast cancer is predominantly in women, men can get breast cancer. We have about 2,800 men annually in the United States who are diagnosed with breast cancer. So we'll get into a little bit later on about the screening for women. There are no screening modalities really for men, but men really need to have an awareness that they too can have breast cancer and should be personally screening themselves and seeing their primary doctor. The last statistic is also quite stark, that over 42,000 women will die annually of breast cancer in this country. So it's very, very important to get an insight and an awareness in the community about screening and prevention. Now, I wanted to talk a little bit about the anatomy of the breast. So let me see if I can use this. So this is our chest wall here. This is our fatty tissue, and then we have our lobules and our ducts and our nipple. So where breast cancer typically starts is in our lobules and in the ductal tissue of our breast. And this is just a close-up of that. Now, I often get the question of why do we develop breast cancer? And unfortunately, there is no sort of one-to-one causal relationship between something that you do or that you don't do that can cause breast cancer. It's typically multifactorial. Often I have patients tell me, I'm the only one who's been diagnosed in my family. They're under the assumption that breast cancer always runs in families or it's always related to an inherited trait, and that's actually not true. Only about 10 to 15% of breast cancers that are diagnosed are related to a mutation that we can test for. So the vast majority of women who develop breast cancer, they are the only one in their family. So just having no family history of breast cancer is not protective from getting breast cancer. Now, this gives you a little insight as to the progression of breast cancer. So sometimes you'll be screened, you'll have a biopsy, and you'll be diagnosed with something called a high-risk lesion, atypical cells. And you say, well, why should I remove those? And the reason is because there is a progression from normal cells to atypical cells, which eventually, under certain circumstances, can become cancerous. So this is where we want to be with our screening. We want to find you when you are just manifesting atypical cells and not when you spill over into this area of cancer, okay? So you've probably seen this statistic before. About 12% of women are diagnosed with breast cancer. That's 1 in 8. So again, it's typically someone who is the only person in their family. There's not just sort of this continuous, oh, my grandmother, my mother, my sister. So what are the signs and symptoms of breast cancer? Now, again, we want to get into screening where you are diagnosed before these symptoms or signs start to manifest. However, sometimes you get clear screening, and despite a normal screen, you start to manifest some signs that are suggestive of something going on. And those can be signs of a palpable mass. So it's really, really important when you are, taking care of yourself that you are mindful of different changes in your breast. Although you may see your doctor annually, you're with yourself every single day. So subtleties or nuanced changes may not be something that your doctor can pick up, but you, with yourself, you can notice that something is a little bit different. So that should absolutely cause you to alert your primary doctor and maybe go in for imaging prior than you are scheduled to get your imaging. But you can have, again, signs of palpable mass. You can have changes in the shape or the contour of your breast. You can notice that the nipple starts to flatten or become inverted. Sometimes patients have nipple discharge, or they have a textural change in their skin. Those are all signs that you should be looking out for to suggest maybe something going on. And don't just assume it's an infection. Sometimes it's a little bit more or a lot more. Now, as far as breast cancer goes, there are 5 stages of breast cancer. The lowest stage is stage 0. This is what we call in situ breast cancer. And that's when the breast cancer is confined to the breast duct. It has not sort of gained the ability to move or to spread. But as breast cancer starts to evolve, it can become larger in the organ that we find it in the breast, or it can start spreading into the lymph nodes or the bloodstream. And that's where your stage starts to kind of climb up here. So this is stage 4 breast cancer, which is where it's disseminated widely. So this again is not where we want to be. We want to be down here. This is where breast cancer is curable, when it's in situ, stage 0, or when it's in an early stage. Now I want to talk about risk factors. So there are certain things that we can sort of glean from people to determine what their risk of developing breast cancer is. And this is really important because to be able to be identified as a high-risk patient, a high risk for developing malignancy in the future, will have an impact on what your screening schedule should be and sometimes what your screening modality should be. But some of the risk factors are definitely being a woman. Women are predominantly, when compared to men, diagnosed with breast cancer. So gender and age are our 2 biggest risk factors. The older you get, and again, being a woman gives you a higher risk of, of developing breast cancer. The other is these genetic mutations that I mentioned. And although they only account for about 10 to 15% of all diagnosed breast cancers, they are important to identify populations of people who may deserve genetic testing early on before they again manifest signs and symptoms or a diagnosis of breast cancer. The other thing is family history. If you do have a family history of multiple relatives with breast cancer or ovarian cancer, that is something that can put you in a high-risk category. So again, that may impact your screening schedule, when you start your screening, and whether you're a good candidate for genetic testing. But sometimes you can have a significant family history, yet there is no genetic mutation evident in your blood. And that could be a reason that just the genetic defect hasn't actually been found yet. So just because you have a negative genetic test doesn't mean that your family history doesn't impact your a slightly increased risk of developing breast cancer. The other risk factor is, again, a personal history. So if you've had breast cancer before, or if you've had one of these atypical lesions, that can put you in a high-risk category. Also having dense breast, and you've probably had mammograms, and you see this sort of statement there that mammograms or dense breast can obscure mammograms. Dense breast have a higher risk of developing breast cancer, and the density of the breast can interfere with the mammogram's ability to see a breast cancer. So patients with dense breasts often require ultrasound and MRI as part of their screening. Reproductive history, starting your period early, having menopause late, just basically being subject to hormones for a long period of time, or taking exogenous hormone replacement. Those are all considered risk factors for breast cancer. Now, as far as those risk factors, those are the risk factors that we really can't control. Those are things that, we're born with. They're part of our family history. We have no control over those risk factors. But there are some modifiable risk factors that we have some semblance of control over. And so that is what I try to help my patients focus on when they're not necessarily having cancer, or once they've already been diagnosed with cancer. And that can impact their risk of recurrence and their survival. So some of those modifiable risk factors are, being physically inactive. Studies are very clear and are coming out that exercise definitely decreases your overall risk of all types of malignancy, breast cancer included. And if you are a patient who's had breast cancer, being physically active can decrease your risk of recurrence. So exercise is absolutely one of the best medicines. The other is controlling your body weight. Patients who are over their ideal body weight, morbidly obese, they also have an increased risk of breast cancer. That's something that we can modify. Also taking exogenous hormones, hormone replacement therapy, that's something that can impact our risk of breast cancer, drinking alcohol, or not having children. So again, those are the modifiable breast risk factors. Now, getting into the meat of the matter is really, again, the screening. As I showed earlier, there is a progression of atypia to stage 0 breast cancer to invasive cancer. And the studies are very clear that when the earlier stage that you diagnose breast cancer, you have a higher risk rate of cure. And that's absolutely what we want. So although you can physically examine yourself, which I do encourage, we want to find breast cancer or atypia when it is not palpable, when you are not manifesting any visible sign of change in your breast, because that can be associated with a higher stage, which decreases your risk of cure. So mammography is the screening modality of choice. It is very, very important to start your screening mammograms. Depending on your risk factors, you may need to start your screening mammograms prior to the age of 40. It's important to note that although the vast majority of women are diagnosed with breast cancer over the age of 50, 1 in 6 breast cancers are diagnosed in patients under the age of 50. So being young does not protect you from developing breast cancer. So starting your screening for an average risk patient at the age of 40 is important. And if you are a high risk patient, starting that screening earlier is very important. And I think that last statistic is very telling, that 70% of women that die from breast cancer in their 40s belong to the 20% of patients who had not been screened. So that means that they're finding their breast cancer when it is a later stage. So again, starting your routine screening at 40 saves 100,000 lives every decade when you start your screening earlier, as opposed to starting your screening at the age of 50. Black women are particularly high risk for developing breast cancer at earlier ages and in higher stages, and Black women actually die at a higher rate from breast cancer. So, there's a sort of a misconception that certain populations don't develop breast cancer. That's absolutely untrue. And again, in African American women, our rate of death and finding it at a later stage is higher. So that's very, very important. Now, mammograms are also important, again, because they have a direct impact on what your treatment options are. So if you delay getting your screening and you find your diagnosis or your cancer at a later stage, you often require a more extensive surgery, meaning a mastectomy as opposed to a lumpectomy. And you also may require adjuvant therapy, i.e. chemotherapy. So screening mammography is extremely important. This is a picture of a mammogram machine. I think everyone in here is probably very aware of what this is. Now we do the 3D mammograms, which have the benefit of taking very, very thin slices and being able to see cancers better in a dense breast. And all of our centers at Torrance, Torrance Memorial, they do have 3D mammography capability. So just getting back to when should you discuss your risk with your provider. So as I mentioned, average risk, we want to start our screening mammography at 40. How do you know if you're high risk? you want to talk to your primary care doctor. You want to go through the nuances of your personal history, of your family history, of other risk factors that can put you in a category of a patient who should actually be getting their imaging done maybe earlier than 40. Maybe you should get your imaging starting at 30 or at 25. Or maybe you should get genetic testing. So it's very, very important to have that kind of dialogue with your primary medical doctor so they can have a individualized plan for you as far as screening goes. So I just wanted to just show a little bit of a dense breast. So this is what a dense breast looks like when you compare it to a breast that's not dense. So this is dense breast. This is a not dense breast. If you have a very small malignancy in here, it's much more difficult to pick this up than if you're looking at a breast that is sort of more fat than fibrous tissue. So a patient with a dense breast, although they do well, with a 3D mammogram, we also like to do an MRI and an ultrasound on a patient with a dense breast. So density of the breast does matter, and again, it has a direct impact on what your screening should be. So I don't think I'll have time to go through this, but I wanted to kind of debunk some of the misconceptions about breast cancer. We already talked about being young is not protective from developing breast cancer. So starting your conversation with your primary doctor when you're young, especially if you're in a high-risk population, is very important. You don't wait until 40. You certainly don't wait until you're feeling something different about your breast. The other thing I wanted to point out again is for African American populations, although we are diagnosed at a lower incidence, we die at a higher rate and are diagnosed in later stages. So for primary care doctors in the community and for patients, you have to understand that that in and of itself is a high risk, and you may need to be screened earlier or on a different schedule. The other we debunked already is that not having no family members is not protective. So just because you don't have family members with breast cancer does not mean you don't need to be screened, and you don't need to have a personal awareness of your own risk of developing breast cancer. The other question I get, or a statement I get a lot, is from patients who come in and say, you know what, just remove both of my breasts because I don't want to get breast cancer. Unfortunately, when we do mastectomies, although it removes a significant amount of breast tissue, it doesn't remove all of the breast tissue. So you do still have a risk of developing breast cancer even with bilateral mastectomies. So although there's no direct screening modalities that we do after bilateral mastectomies, you still have to, again, engage in your annual care with your primary doctor or your medical oncologist. Again, breast feeling normal, that's what we want. That's why mammograms are important, to find something when it is not palpable and you have no changes in your breast. I also wanted to talk about this briefly. I often have patients who have had their imaging, we see something suspicious, and they have a lot of reluctance to do a biopsy because they're afraid that introducing oxygen or introducing trauma to that site is going to disseminate the cancer broadly. There has been no study that shows that poking a breast and doing a biopsy will disseminate cancer widely or in the breast. So if you get a mammogram or you get some imaging and something looks abnormal, go that next step and get a biopsy. More often than not, it's something benign, but sometimes it's atypia or malignancy. So we want to be in the driver's seat on that. The other is, I don't want to know if I have breast cancer because the treatment is so much worse than the disease itself. And that's not true. Even for patients who require chemotherapy, they often do quite well with chemotherapy. And more often than not, when you diagnose patients in an earlier stage, they do not require chemotherapy. And surgery and radiation therapy is well tolerated. The last thing I wanted to say is I have patients who come in and they have an anecdotal story about a friend of a friend who had this experience with breast cancer, and so it really imprints in them that they don't want to go down that path. I always tell people, every cancer is different, every patient is different, and everyone's experience is different. And so even if you're going through this journey, know that there are cures out there, there is support out there, and you can have an individualized care plan that will address your particular breast cancer. There is no one type of breast cancer and no one type of patient. And then just quickly about prevention, what can you do to lower your risk? Again, maintain a healthy weight. You want to exercise, you want a healthy diet, limit your alcohol intake, you do your self-exams, and more importantly, you meet with your primary doctor, figure out your risk rate, and then you determine your modality of screening and the frequency of that based on your own individual risk. Okay? So sorry. Thanks, guys.
Phenomenal lecture. Thank you so much, Dr. Ali Jones. I mean, I'm sure that you all enjoy it. It was very informative. Thank you so much. And please hold your question for the last, because we want to make sure we are going to all of the great lecture that we are waiting for today. So our next speaker is Dr. Andrew Horodner. Dr. Andrew Horodner is an oncologist, hematologist, and he graduated from medical school from the University of Arizona and completed his internal medicine residency at the UC Irvine and the fellowship in the hematology and medical oncology at Harbor UCLA Medical Center, where he previously served as a volunteer faculty for many years. Dr. Horodner joined the group of formerly known as a Cancer Associates out of his fellowship in 2007 as a practicing the hematologist and medical oncologist. He has remained with the group since then, and including its move to Torrance Memorial Medical Center in 2013 and into the Hunt Cancer Center at the end of the 2019. Dr. Horodner holds several leadership positions, including co-director of the Thoracic Oncology Program, chair of the Cancer Committee, and chair of the Lung Tumor Board at Torrance Memorial. He is the site principal investigator for several lung cancer clinical trials at the Hunt Cancer Center in affiliation with the Cedars-Sinai. He served as a member of the Cancer Support Community Professionals Advisory Board, and he is married and has 21-year-old son and a 15-year-old daughter. Please help me welcome Dr. Horodner.
Thank you very much. There we go. So we're going to shift focus and talk about lung cancer prevention and early detection. So in terms of my overview of the presentation, we're going to first show some mortality and incidence data, talk about some of the subtypes of lung cancer, some of the risk factors, predominantly tobacco, and also talk a little bit about vaping. We'll talk about prevention, smoking cessation, and look at some of the low-dose CT lung cancer screening protocols that are done, and also look at our lung cancer program at Torrance Memorial. So globally, the most common cancer in the world is lung cancer in terms of incidence and mortality. In men, hit the right button. In men, lung cancer is the most common and the most lethal. But in women in the world, breast cancer is the most common and the most lethal, followed by lung cancer. In the US, it's a little bit different. The most common cancer in women is breast cancer, and in men is prostate cancer, whereas lung cancer is the most lethal in both genders. This is the World Health Organization classification of lung cancer. So it's a little bit small, sorry about that. But when you talk about lung cancer, most of the time we're talking about non-small cell lung cancer. And this includes different types, including adenocarcinoma, squamous cell carcinoma. Adenocarcinoma is about 50% of lung cancer. And some of these adenocarcinomas are not tobacco related, and they have a driver mutation, such as a mutation in the EGFR gene, which can be targeted with pills. So what are some risk factors? Well, tobacco is the main one. So lung cancer is linked to tobacco in about 80 to 90% of cases. This includes cigarettes, but also pipes and cigars. Cigarette smoke contains more than 7,000 chemicals, about 70 of which are carcinogenic or cancer-causing per the FDA. And a smoker's risk of lung cancer is 10 to 30 times greater than a non-smoker's. So if the average person that doesn't smoke, the risk of lung cancer is less than 1%, a smoker's risk might be 10 to 30%. And the risk increases with the number of cigarettes smoked per day and the number of packs or cigarettes smoked per year. And in some of the data, we often look at the number of pack years, which is exactly that. For example, 1 pack per day smoked for 30 years is 30 pack years. So smoking cessation, importantly, even though tobacco and smoking cause lung cancer, if you stop smoking, you can decrease the risk of lung cancer. And smoking, importantly, is a risk factor for other cancers and other poor health issues, including heart disease and stroke. And this, I think, is very provocative in that secondhand smoke exposure is also linked to lung cancer. In the US, more than 7,000 people die every year from lung cancer due to secondhand smoke exposure, per the CDC. But what about vaping? There's a lot of questions about, is vaping safe? What is the risk? Electronic cigarettes and other electronic nicotine delivery systems that they call ENDS have been available in the US for about 20 years now. And these are typically battery operated. They have a liquid that most often contains nicotine, but not always. But the liquid also has chemicals in it that are known to cause cancer. And this produces an aerosol that the person inhales or vapes. Vaping definitely has harms. While it's promoted as a tool for smoking cessation, unfortunately, by flavoring these products, it has increased the appeal to young people. And many of these young kids didn't smoke tobacco before. And what studies have shown is that kids who vape have a 3 to 4 times more likely chance to smoke tobacco in the future and increase their risk of lung cancer. The exact data about vaping and lung cancer risk are a little bit limited, and they're confounded by other variables. It's hard to sort of separate people's use of cigarettes as well. And since vaping has only been around for maybe 18 years or so, we may need more time to see the long-term effects. While nicotine does have health risks, including addiction, which is the main problem, it's probably not directly linked to lung cancer. And an important point is, even though these ENDS products have fewer cancer-causing chemicals than combustible or smoking tobacco, there is evidence that links these products, ENDS and e-cigarettes, to DNA damage, damaging the cells at the kind of the blueprint level, and inflammation causing. And these are steps in the development of lung cancer and other cancers. So Eric Weiner, who is a breast oncologist, but was the former head of the American Society of Clinical Oncology, was quoted as saying, "While we do need more research to fully understand the long-term health effects of ENDS, the harms of nicotine addiction, especially for young people, are well known. And additionally, since it's increasingly clear that ENDS expose users to carcinogens and increase the odds that a young person will go on to smoke tobacco, state and federal policymakers, along with other stakeholders, must advance policies that curb ENDS use in non-smokers and advance research on the long-term health impacts of these products. So the CDC does not consider electronic cigarettes or ENDS safe, and they directly state in their web material that they should not be used by youth or adults who have never smoked. The FDA has mandated restrictions on ENDS. They are restricted to purchase for people 21 years or older, and they say that they'll prioritize enforcement against any illegally marketed ENDS products, particularly ones that are flavored that don't have a tobacco or menthol flavor. But as I have a 21-year-old and a 15-year-old, I well know that they have plenty of access to these vaping products in their schools. What about smoking marijuana and cocaine? Well, the current medical thinking is that also, yes, this increases the risk of lung cancer too. But similarly, it's kind of hard to understand the exact magnitude because a lot of patients that practice these behaviors also smoke tobacco. There are, however, some published studies that show that in the bronchial airways of people that smoke marijuana, under the microscope and at the DNA level, there are cancerous or precancerous changes that are similar to that is what is seen in the airways of tobacco smokers. In terms of less common risk factors for lung cancer, these are somewhat well known. Asbestos does increase the risk of lung cancer and mesothelioma, and this risk is thought to be more common in people occupationally exposed to asbestos rather than having asbestos in the home. Radon is a decay product of uranium and radium, and this can be found in soil and rock and groundwater, and so people can be exposed to this in their homes, unfortunately. There's other environmental and occupational exposures, like arsenic and formaldehyde and hydrocarbons and metal dust that people can be exposed to that are known to cause lung cancer. There are chronic, the smoke from cooking and heat from indoor burning of wood and coal is known to increase lung cancer risk. And then air pollution and diesel exhaust, not surprisingly, increase lung cancer risk. There was actually a study in England looking at never smokers. And these patients that develop adenocarcinoma will frequently have a mutation in the EGFR gene. And it's really not well understood why that happens. But in this study, they looked at the amount of particulate matter people were exposed to in the environment. And as the particulate matter index went up, there was an increased risk of EGFR mutated lung cancer in these non-smoking patients. Prior chest radiation, such as radiation to treat esophageal cancer, breast cancer, can slightly increase the risk of lung cancer, although this risk is quite small and shouldn't be emphasized. Chronic inflammatory diseases like COPD, tuberculosis exposure, fibrosis can increase lung cancer risk. Genetics, as opposed to breast cancer, not really well understood. Most lung cancers are not related to genetics, although there seems to be an increased risk of lung cancer if your family member has lung cancer, irrespective of tobacco use. So there's something there, but we haven't quite identified why. And there are some familial cases where that EGFR gene that I was talking about can be hereditary. They actually find it in the germline of patients, and that can be passed on to their kids, but that's not the typical way that this happens. What about hormone replacement therapy? Taking estrogen and progesterone for women that are in menopause, it's not really thought to cause lung cancer, but in the Women's Health Initiative, a study that was done 20 plus years ago, they found that in those women who developed lung cancer, if they were on HRT, their risk of death from lung cancer was significantly higher. So in that case, we would tell people to stop using the hormones. And there's really mixed data as opposed to breast cancer about race and diet and body mass index and weight with respect to how this influences lung cancer. The clinical trials and studies have really given inconsistent information. So how do we prevent lung cancer? Well, some of these things are obvious. Don't smoke. Avoid secondhand smoke exposure. So this is sort of a plea to the smokers. Think about who's in your home with you, children, spouse. Excessive smoke exposure to them can increase their risk of lung cancer over their lives. Don't vape, particularly if you've never started smoking. Stop smoking, it's never too late, and we'll show some data about that in a second. There are combined studies that show behavioral counseling as well as medication are best at leading people to stop smoking. We have smoking cessation programs in many different places. As part of these programs, it's integral to set a quit date and learn coping mechanisms on how to deal with withdrawal and other related issues. Here at Torrance Memorial, our nurse navigator who's in the audience, Amy Lowe, has a smoking cessation class, and I think she'll begin again in January or February with these free classes on Tuesday, and there's contact information if you're interested. The American Cancer Society has a web-based program that's listed there, and probably we can provide these slides to people afterward if they'd like. In addition to behavior, medications are helpful. Chantix has been shown to effectively help people stop smoking, as well as combined nicotine replacement therapy. So a long-acting nicotine product like a patch, in addition to a short-acting product like a gum and a lozenge together, are very effective. The other drug, Wellbutrin, in certain studies has not been quite as effective as Chantix. So in terms of prevention of lung cancer, while these electronic nicotine devices may help adults transition away from more harmful tobacco and cigarettes, there have been no products that have been approved by the FDA for smoking cessation purposes. Several studies have actually shown that using electronic cigarettes or ends are actually effective in helping people stop smoking. The problem is that these devices use nicotine, so they're very addictive. And so many times people just transfer from tobacco to the electronic device and they can't get off of that. And there are chemical carcinogens in these vapors as well. And we don't really understand long-term what the true consequences of that are. So it's really better, I think, for patients just to go to behavioral counseling and medication and other nicotine replacement products that don't expose you to cancer-causing chemicals. Smoking reduction can decrease lung cancer risk, so that's important too. Even if you can't stop, if you can cut back, that's helpful. And people smoking at least 15 cigarettes a day, if they cut back by half, they decrease their lung cancer risk by 1/4 after 18 years, which is pretty substantial. This is our smoking cessation flyer here at Torrance Memorial. I think this curve is pretty provocative in terms of how smoking cessation decreases lung cancer risk. So what this sort of is saying is, if for certain you were going to develop lung cancer, you had a 100% chance, if you stop smoking, then by 10 years later, your risk reduces to about 30%. By 20 years, it reduces to 20%. By 30 years, it reduces to 10%. So what can we do to screen for lung cancer? Well, low-dose CT screening is a sensitive modality for detection of cancer, specifically looking at these spots in the lung that we call lung nodules. And it can detect cancer at an early stage so that we can cure it. These low-dose CT scanners, they generate high resolution with multi-detector procedure, and they have about 1/5 of the radiation exposure as a traditional CT. Earlier stage disease, just like in breast cancer, has a higher cure rate and an improved survival. The U.S. Preventative Services Task Force recommends the following. Annual low-dose CT screening should be done for high-risk people, those ages 50 to 80, with at least a 30-pack year history of smoking, and they have to be a current smoker or have quit within the past 15 years, which some of us would argue that maybe they should have a longer period of time that they quit, but they still have risk, it just is lower. Even though CT screening catches lung cancer early, it does have potential harm. There is potential false positives. Sometimes a lung nodule gets biopsied and it's not malignant. And while that might reassure people, for some people it can cause anxiety. Sometimes people require further imaging studies more frequently because of this, so we have to think about those things. This is an example of a lung nodule in the right middle lobe of a patient seen on a CT scan, and this was biopsied and showed adenocarcinoma. This was the National Lung Screening Trial, which basically put low-dose CT screening on the map. And this study looked at annual lung cancer low-dose CT screening for 3 years compared to 3 years of just simple chest x-rays. And they looked at 53,000 high-risk patients in the US. So their criteria were a little bit different than what the US Preventative Service Task Force states. The age range was a little narrower. It was 30 pack years, but the current smoking and the quitting within 15 years was similar. And the primary analysis was a comparison of lung cancer-related mortality between the two screening tests. So on the left of the screen, these are for low-dose CT in the top graph, and for chest x-ray, there were 1,060 lung cancers diagnosed in the low-dose CT, and in the chest x-ray, it was 941. So more were detected because it's more sensitive. But more importantly, the primary endpoint was chest x-ray. In that arm, 443 deaths from lung cancer occurred, and only 353 deaths occurred in the low-dose CT arm. And this is because, again, CT scanning is much more sensitive. It can pick up cancers at a much earlier stage. Frequently, chest x-ray does not catch these tumors until they're much larger and more advanced. So this was a relative reduction in the rate of death from lung cancer of 20%. It's a huge reduction in lung cancer death by doing CT screening as opposed to just an x-ray. And what they showed is that 320 low-dose CTs would need to be done in order to prevent one lung cancer death. And that's a large number, but I think it's probably invaluable if you're the patient that would have died from the cancer. Low-dose CT screening is offered here at Torrance Memorial, and here's some information. It's usually covered by insurance, but there is a low-cost, out-of-pocket $205 fee if you can't get it covered. And here are some of the low-dose CT screening data provided by Trish Steins, who's in the audience, who's our lung cancer program coordinator. And so this basically shows that in 2015, we started doing low-dose CT, and you can see over the years, this is sort of caught on like wildfire. Now all of the primary care doctors and other providers know that we should be doing this. Last year in 2023, of the 962 scans that were done for screening, 16 lung cancers were found. So it's about a 1.5% or so cancer detection rate. So what if you have an abnormal low-dose CT, then what happens? Well, I can tell you what happens at Torrance Memorial. So we have a lung nodule clinic that happens on Friday mornings, and this occurs directly after the Lung Cancer Tumor Board. And this is a multidisciplinary conference. So we have our lung program coordinator present the histories of these patients that have had low-dose CT or other lung nodules screened by the radiology department. And then a radiologist shows these abnormal imaging studies on the screen, and we all look at them together. The lung specialist, the pulmonologist, and the surgeons then discuss what is the true concern for lung cancer and what should be done next. And if necessary, should we do a biopsy, where our lung specialist, Dr. Abe and Dr. Eltawil, can do a robotic bronchoscopy where they can put these fiber optic tubes that are very small deep into the lung and biopsy very tiny nodules and make a diagnosis, whereas in the past we couldn't capture these nodules. And sometimes the lesion may be so suspicious that the surgeon just wants to meet the patient and take the patient to surgery. Medical oncologists like myself and radiation oncologists are there to talk about if cancer is diagnosed, then what? Sometimes we'll offer patients chemotherapy, immunotherapy, targeted therapy like pills for the EGFR mutation. And radiation oncologists offer radiation. And then the recommendations are provided to the primary care doctor or the physicians ordering the scan. I think this is my last slide, so I'll hurry up. Importantly, each new lung cancer case that's diagnosed is presented at the Lung Cancer Tumor Board every Friday. So we have this conference with everybody that I just mentioned, including a pathologist who looks at the tissue under the microscope with us. And it's not just a second opinion. It's sort of like getting 10 opinions. You have multiple practitioners in different fields, whether they be the diagnostic pulmonologists, the medical oncologists, the radiation doctors, or the surgeons, And we talk about what else do we need to do to make a diagnosis? How do we stage the extent of the cancer? And what are the treatment options? Well, I said genetic testing is often not really applicable to lung cancer. Sometimes it can be, and we have a genetic counselor that can help us do testing and counsel patients. And we also have cancer supportive services. So we can make referrals to a lot of these different departments. I just wanted to emphasize that the Hunt Cancer Institute is an integrative, multidisciplinary cancer program, and we're very proud to be part of this at Torrance Memorial. And we have all of these different fields of specialty that help the patient on his or her cancer journey to get through it in the best shape that they can. We have dietitians, we'll hear from Erica shortly. We have psychosocial counseling with social workers and therapists. The cancer support community has counseling and support groups that are totally free for patients and their families. For patients that are impaired by their cancer, there's physical therapy or occupational therapy. We have pain management providers that can help with pain control. Our palliative care team can help with pain management, supporting oxygen, nutritional support, whatever the patient needs to make their progress throughout their treatment a little bit easier. And we have integrative oncology. Susan Starr, our nurse practitioner, has sort of spearheaded this, and we have an important program at the Hunt Cancer Center where we focus on nutrition, we focus on patient well-being, we focus on mindfulness, and we focus on getting patients in the right frame of mind so that they can get through their cancer in the best shape that they can. And in the audience here, we have Fabiana, who's one of our integrative therapists who works at Torrance Memorial in the hospital mainly, but also at the Cancer Center and helps patients with techniques like Reiki and aromatherapy, which have been really invaluable to many patients. We have clinical trials. So I'm in charge of some of the clinical trials through our Cedars affiliation. So patients can enroll on studies without having to leave the South Bay. They can go, they can be treated here and get experimental drugs that they would otherwise have to travel 30 miles for. And then at the end of the conference, I write a recommendation, and we provide that to the primary care doctor and the relevant providers. And then our nurse navigator, Amy, is here to help expedite patients' referrals and help support them through the process. And I think that's all. Thank you.
Thank you so much, Dr. Horodner. Such a great, amazing lecture. You know, I was thinking, listening to those lectures, I was thinking how we should be grateful to the science that, you know, every sentence that they are talking about is coming from the textbook and guidelines. And then for every single sentence, there has been 100 million hours of the person-hour time of the doctors, scientists, and patient putting together to get to those information. It's not like a doctor sitting together, okay, let's discuss which type of the measure or modality we want to do for the screening or for the treatment or those things. Every of those information comes from the evidence-based guideline-directed information. So, and then we are lucky more because our cancer group is one of the best, not only in the Southern California, also in nationwide. We have one of the best cancer center. So by saying that, we are going to introduce our next speaker, Dr. Neil Bhayani. Dr. Bhayani is the director of the liver and pancreatic and complex cancer surgery. He is the director of the reflux and esophageal surgery at the Association of the South Bay GI. South Bay Surgeons. He was also elected chair of the liver, pancreas, gastrointestinal cancer program at the Torrance Memorial Medical Center. Dr. Bhayani's busy practice include the major abdominal cancer operations and gastric and esophageal surgery weekly. He is genuinely interested in the caring for the patient with complex cancers, reflux and abdominal problems, and using the newest minimally invasive techniques. Having the 3 extra year of training Beyond the general surgery, Dr. Bhayani uses laparoscopic surgery to reduce pain and speed up the recovery after the major pancreatic, liver, stomach, and esophageal surgery. He regularly collaborates in the clinical research project with the researchers nationwide to directly improve the patient's care. Dr. Neil Bhayani has been voted a top doctor by LA magazines. Please help me welcome Dr. Bhayani.
Thank you for that very generous introduction. And more importantly, thank you all for coming and taking time out of your evening to learn a little bit about prevention. When Dr. Rezaeian started this talk, I think she really started it with the note that I wanted to emphasize the most, which is prevention. And is cancer preventable? And I'm going to start kind of this talk, and I think if my takeaway from Dr. Ali Jones, if I had a clicker to count the number of times she said mammogram, I think my thumb would have fallen off. And I think the same thing is true for Dr. Horodner. If he could tell you to stop smoking on each slide, I think it was at least on each slide at least once. So the sum of my presentation is the word colonoscopy. Okay, so with a colonoscopy, colon cancer is almost entirely preventable. And that is kind of the beginning, the middle, and the end of my talk. Let's see how many different ways I can say it. Okay, so colon cancer is cancer that begins inside the colon, no matter where else we might find it. It's cancer that begins in the colon. This is what the inside of a colon looks like when you get a colonoscopy. Quick show of hands, who here has had a colonoscopy? I'm not going to shame the people who haven't, but thankfully almost everyone raised their hand. So this is what the GI doctor sees on the inside of a colon. You guys walked through it on your way in here. It should be mostly smooth, okay? This is the alternative, okay? So this is what we would call a polyp. You can't really tell whether it's cancer or not until the GI doctor takes it out and the pathologists look at it under the microscope. This, however, everyone can tell this is a lot uglier looking than this. And so even without putting this under the microscope, the GI doctor is going to come out and say, you know, there's a very high risk of cancer at this location. And again, to Dr. Ali Jones' point, we never want you to get here. The goal of colonoscopy is to find a polyp, a precancerous step that is removed, and then you're done. Okay. So again, to echo everybody else, no symptoms equals the best outcome. Most cancers do not have symptoms. They do not cause pain. They do not cause weight loss. They do not cause blood in the stool or changes in your bowels. And so screening, taking somebody who has no symptoms, who's just going to the doctor just to get checked, those are the people, when you get screened, that have the highest chance of a cure. Now, removing an early cancer, whether it's a precancerous polyp or something that was just found, oh, by the way, reduces your chance of dying from colon cancer by 90%. It's extremely effective. Colon cancer is almost entirely preventable with a colonoscopy. Let's say we're not on target. Let's say we're not seeing our GI doctor and our primary care doctors as often as we should, and you start to have symptoms. Well, what should you be looking for? Or if your friend or neighbor starting to have problems that they're talking to you about, when should you really stress the need for a colonoscopy? Blood in the stool, thin caliber stool, something that looks stringy or like a worm. Pain, cramping, this is the signs of a blockage, a cancer that has gotten so big that it's actually blocking the colon. And then weight loss and fatigue are last resort symptoms that you find when the cancer typically has spread to other organs. Prevention. I'm not going to spend too much time on this because the science on this is quite murky. What that means is anything that we think there may be a benefit for, that benefit is small, and there's a lot of disagreement on our data. But there are things that may have some benefit. Aspirin for 5 to 10 years, or non-steroidal anti-inflammatory drugs can reduce the risk of cancer. vitamin D supplementation, plant-based diets, which I think Erica will talk about in a little bit, and then tobacco cessation. It doesn't just reduce your risk of lung cancer, it very much reduces your risk of colon cancer and other cancers. So screening works. Colonoscopies work. Colonoscopies find precancers, which is what we want, and then also find cancers. Now, I'm going to take a little bit of a detour here. As I said, this talk starts with colonoscopy and ends with colonoscopy, but we're going to take a detour and talk about all the other stuff you guys have heard about that you see in commercials and in booklets. The other one was looking at chemicals that fall off of the outside of cancer cells, but let's look at stool DNA. Is that more accurate? Well, it is more accurate, but you still have a 10 to 15% false positive rate. Okay? So of the people who test positive, all right, 10 to 15% don't have cancer. You're still missing a lot of cancers. And again, the moment this turns positive, you need a colonoscopy. So who should get screened? Definitely everyone over the age of 50, but a few years back, we lowered that to the age of 45. So 2 weeks from now, I'll have my first colonoscopy ever. I'm very excited. Those of you who have had it have been through the prep. And that, from what I understand, is the worst part of it. I'm really looking forward to my 2-liter bottle of Coca-Cola. That's going to be my caloric intake for the day. Everyone's got something different. I think that's going to be my treat to myself for my colonoscopy. So 45 years and above, men and women, there are certain demographics that are slightly higher risk. So African Americans have a slightly higher risk of colon cancer and really need to discuss with their primary care doctor whether or not it's worth screening a little earlier. And then how often do you screen is going to be based on what they find. So it depends on what they find. Maybe if you're totally squeaky clean, it's every 10 years. And otherwise, you need to get checked either 1 year, 3 years, 5 years, etc. If you're only going to do stool tests and you're not going to do a colonoscopy, please, 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 at least go and get that done on an annual basis. Okay? All right. So who is too young to get a colonoscopy? Really no one. If you have symptoms, you need to go get checked. But if we're talking about screening people who don't have symptoms, you should start 10 years before the person in your family that had a diagnosis of colon cancer. People who have inflammatory bowel disease, so that's ulcerative colitis and Crohn's, any kind of chronic inflammatory process of the colon. We saw that in the lung cancer situation also, where inflammatory diseases predispose you to colon cancer, or to lung cancer rather. Genetic diseases are a cause of colon cancer, but like the other cancers, it's about 5%. It's quite rare. So who's too old for a colonoscopy? This frequently comes up. The Preventive Services Task Force said, if you're over 80, you don't need a colonoscopy. That's not actually what they said, but that's how it comes across. And the answer is that's not true. What they're saying is you don't, over the age of 80, you don't go and get a colonoscopy just because. It has to become a more thoughtful process at that point. So if you are weak, frail, with lots of medical problems, living on oxygen, okay? You know, there may be some disease that you're dealing with that is more likely to take your life than a colonoscopy. And screening, meaning going hunting for a cancer or precancer that might be small, is not worth your while. But if you're healthy, if you've got a good quality of life, if you've got a decent life expectancy, and if nothing else is going to kill you before the colon cancer is going to get you, then go get your colonoscopy. Because of this misconception, you will find doctors that are reluctant to offer screening to healthy older people. I'm not going to call it ageism, but let's be real. If you're healthy, you should take care of your health. Okay? So, virtual colonoscopy. We do offer this here at Torrance Memorial. Okay? A virtual colonoscopy is a CT scan, and it does have radiation. So a very small risk, just like the lung screening CTs. It is not as accurate as a colonoscopy. Okay? And I think having the colonoscopy in the name makes it sound more accurate, but it's not. It's a CT scan. It's an X-ray. It's looking at shadows, quite literally. Okay? It does have a much higher risk of missing a cancer or a precancerous polyp compared to a colonoscopy. So still not as accurate, but guess what? You still have to do the colon prep. So you're getting a less accurate test, having to go through the same cleanse, and guess what? You have to do it more frequently. And if they find something, even if they're not sure what it is, you end up with a colonoscopy with a second prep. That really just does not sound like a good idea to me. So this is what the colonoscope looks like, okay? The diameter is about that of a nickel, okay? It's shy of a ½ inch. It's really magical what the quality of images they're able to get through this fiber optics these days. So beginning and ending the talk the same way, colonoscopy, colonoscopy, colonoscopy. This is the absolute gold standard. In getting one, you can remove both polyps, which are precancerous, as well as cancers. And we do find stuff on the regular, okay? Most people do not have a squeaky clean, or I should say, up to half of people do not have a squeaky clean colon. They're gonna find something, which is good, because that's what you want. You want something to be found, because you don't wanna deal with the misses, which also happen. And I don't want to oversimplify this, but in the hands of our GI doctors in the South Bay, and we're very lucky to have very good GI doctors, in the hands of our GI doctors, the procedure is safe and extremely thorough and very, very effective. They find a polyp, a mushroom on a stalk, and they use this instrument, which is a little cautery device, a little lasso, to just chip it off like that. They then retrieve it with a little basket and give it over to our pathologists, who are excellent, and they tell us whether anything more is needed, whether this is cancerous or not. So how are we doing? Only 65% of age-eligible people get their colonoscopy. So again, that means starting at 45, people should get it, and most people, honestly, are not. We're not there yet. So I would encourage you, now that you've taken your evening to get educated about it, to encourage your friends and family and loved ones to go see their primary care doctor, get a referral to an excellent gastroenterologist, and go and get screened. And with that, I'll say thank you.
That was truly fascinating. Thank you so much, Dr. Bhayani. So after colon, I think that's a time to talk about the nutrition, how we can eat. So we have Erika Drost, who is the registered dietitian nutritionist dedicated to helping people foster substantial eating habits that promote long-term health and well-being. She holds an undergraduate degree in public health from the Taylor University and the master in the nutrition from the University of Illinois at Chicago. With this background, she had learned the importance of the creating environment in which people can stay healthy, at the same time empowering the people to take control of their health. Erika's expertise spans both inpatient and outpatient setting, where she comes alongside individuals to understand the power of the food in She currently teaches the Cancer and Nutrition series, nutrition during the cancer treatment and the Live Well After Cancer therapy classes. Outside of the work, Erika enjoys traveling, hiking, and soaking up the sun on the beach. Please help me welcome Erika.
Thank you so much for that warm welcome. Are we all awake still? You're with me? Okay. This is the last one, I promise. So I'm very excited to be part of this panel talking about a topic that I love talking about, preventing disease through nutrition. And I think if nothing else tonight reminds us all the power each one of us has to take control over our own health, right? So hopefully you guys are as empowered as I am. So we're gonna dive into the fun stuff, food. Who likes talking about food? Show of hands. Love the enthusiasm. Hopefully you guys are as enthusiastic at the end of the presentation. As fun as colonoscopies are. Sorry, Dr. Bhayani. So with the brief time that we have tonight, we will dive into looking at the role of nutrition in cancer prevention, the top 3 tips for nutrition for cancer prevention, and then some practical applications. So first of all, why is nutrition important at all? Why does it matter what we eat? Well, we know from the research that approximately 40% of all cancers can be prevented. So I'll say that again, approximately 40% of all cancers can be prevented. So I think this is a staggering statistic, right? And again, should empower us, really supporting the idea that, you know, it's the genetics that loads the gun, but it's our lifestyle and our environment that pulls the trigger, right? So we have a lot, how we've been talking tonight, a lot that power that's in our own hands. So these lifestyle modifications listed here, we more or less can control, right? And obviously we're going to focus on the first one, a healthful dietary pattern, but also regular physical activity, maintaining a healthy weight, avoiding tobacco, as we've been talking about tonight, limiting excessive sun exposure, and keeping up to date on our screenings and colonoscopies and vaccines, right? All of these contribute to the 40%. So then diet-wise, what can we do to decrease our risk for cancer development? So we have 3 tips that we're going to focus on, taken from the American Institute for Cancer Research. They actually have 10 recommendations that they put out for cancer prevention. I've condensed the nutrition-related ones into 3, so we'll break those down into more detail. But number 1, eat a diet rich in whole plant foods, as Dr. Bhayani alluded to earlier. Number 2, limit consumption of red and processed meats. And number 3, limit consumption of ultra-processed foods, high in added sugar, sodium, and saturated fat. So first point, eat a diet rich in whole plant foods. So plant food categories include things like fruits, vegetables, whole grains. So these are things like oats, farro, quinoa, whole grain bread, whole wheat pasta, brown rice. Legumes. So these are things like beans and lentils. And peas, peanuts, and soy also fall into the legumes category. And then nuts and seeds. So we want our diet to be rich in these whole plant foods. Whole meaning we're trying to eat these foods as close to their natural state as possible, right? So for example, choosing an apple versus apple juice, or choosing rolled oats versus like oatmeal in a package with some added sugar. But why plants specifically? Why are they so special? For a lot of reasons, this is not an exhaustive list. But most importantly, we know that whole foods, whole plant foods contain a lot of cancer-crushing compounds, right? So they contain antioxidants, phytonutrients, vitamins and minerals, and fiber. So antioxidants are compounds that have the ability to protect our cells from the damage that's caused by free radicals. So if the DNA of healthy cells goes unchecked, the damage of the DNA of healthy cells goes unchecked, the more likely those cells could become cancerous, right? So including enough antioxidant-rich foods in our diet can help prevent against oxidative stress and possible cancer development. So some examples of antioxidants include vitamin C, vitamin E, selenium, and carotenoids. Phytonutrients, or you may have heard them called phytochemicals, this is the same thing. These are naturally occurring plant compounds that protect plants from infection and predators and give plants their color and their pigmentation. So it's actually pretty amazing when you think about it, because these plants use these chemicals to stay healthy and thrive. So then when we eat these plants, they do the same thing for us. They help us stay healthy and thrive. And many phytonutrients act as antioxidants. So similarly, diets rich in fruits and vegetables, which contain phytochemicals, have been shown to lower the risk for developing cancer and other chronic diseases. So this is where eating the rainbow comes in. Different colored fruits and vegetables contain different phytonutrients that play distinct roles in the body. So variety is really key when it comes to plants. There are actually more than 25,000 different phytonutrients. Some are listed here, which you may be familiar with. Allicin, lutein, zeaxanthins, anthocyanins, polyphenols, lycopene, and flavonoids. Sadly, we don't have time to go into the details of each one of them, but a lot of them are being studied for their association with cancer prevention. There is research connecting lycopene-rich diets with possible reduction in prostate cancer risk. Lycopene-rich foods are red fruits and vegetables in color, so think tomatoes, red bell pepper, watermelon. Preliminary data also shows an association between allicin-rich foods, such as garlic and onions, and a decreased risk for GI-related cancers. But more research needs to be done in terms of providing definitive recommendations in terms of intake. But the moral of the story remains, eat the rainbow to get the maximum benefit that these plants have to offer. Vitamins and minerals. So plants contain a myriad of vitamins and minerals, many of which have cancer-crushing properties as well. Some are listed here, but it's important to note that the benefit of these vitamins and minerals and antioxidants really only applies when we're consuming them in food form, not necessarily supplements. So research has not shown antioxidant supplementation or specific vitamins and minerals in like pill or isolated capsule form to be beneficial for preventing cancer. The reason for that is not fully understood, but we know it has something to do with the fact that the whole is more than the sum of its parts when it comes to food, meaning we can't necessarily have a reductionist approach where we think that extracting a certain particular nutrient will do the same thing in the body as consuming that whole food that has that nutrient, but also other compounds that work synergistically. So no magic bullet yet, I'm afraid, in terms of vitamins and minerals. Lastly, plants contain fiber. So fiber plays many crucial roles in the body, including supporting a good gut health. It keeps you feeling full and satisfied to help aid in weight management. It helps to stabilize blood sugar and to improve cholesterol. And it also lowers the risk of a myriad of different chronic diseases, including cancer, specifically colorectal cancer. So there is definitive data to show that for each 10-gram increase of dietary fiber per day, there is a decreased risk for colorectal cancer by 7%. So fiber is one of those things that we really can't go without in our diets. Moving on to our second tip, which is to limit consumption of red and processed meats. So processed meats is that top category. And these are meats made by salting, curing, smoking, fermenting, or preserving. So this includes things like bacon, hot dogs, bologna, salami, sausage, corned hash, Spam, deli meats, and pepperoni. I hear some people kind of groaning. And then red meats are any beef, pork, or lamb. So, most of the research, again, is connecting this diets that are high in these types of foods with an increased risk for developing colorectal cancer. There really is no safe recommendation when it comes to processed meat consumption. We really don't want it to be a part of our everyday diet. But for red meat, we just want to limit. So the current recommendation put out by the American Institute for Cancer Research is to limit red meat consumption to 12 to 18 ounces per week. But I've seen as low as 3 ounces per week being beneficial too. So our last tip is to limit consumption of ultra-processed foods high in added sugar, sodium, and saturated fats. So we live in a world where hyper-palatable food is accessible to us 24/7, right? Fast food, convenience food, things that come in boxes and packages. And a lot of these are high in the 3 S's, as I like to call them: the sugar, the added sugar, the saturated fat, and the sodium, the salts. So the issue with these foods comes down to the fact that diets that are higher in these types of foods are typically associated with greater risk for developing overweight and obesity. So we know that overweight and obesity in and of themselves is a risk factor for developing at least 13 different types of cancers. So eating less processed food can help maintain a healthy weight. So those were our 3 tips, but I would like to include an honorable mention for alcohol. The current recommendation for cancer prevention is to limit alcohol to 2 drinks a day per men and 1 drink a day for women. And 1 drink being 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of liquor. But at the end of the day, alcohol really is a carcinogen. So more and more research is coming out to show that the closer we can get that to 0 drinks per day, the better. So less is definitely more when it comes to alcohol. Okay, we made it through our tips. So then practically, what does this look like? How can we apply these concepts to our meals? So this might be a familiar image to some of you. It's what we would call the old American plate or the standard American diet, acronym SAD, where the meat is kind of at the center of the plate, right? And then you would have a starch, probably with some butter on it, right? And then maybe a starchy vegetable like corn or peas. So then the goal would be to transition to what we're calling a new American plate, right? Where you can see there's a lot more color, a lot more diversity of fruits and vegetables, and plants are more at the center of the plate. And the meat portion is smaller and maybe more lean. So really aiming to have like 2/3 of our plate filled with whole plant foods, right? Whole grains, fruits and vegetables, legumes, and then 1/3 or less for protein. So some quick takeaways or tips. Try experimenting with different kinds of protein, right? Like focusing more on plant-based sources of protein. For example, swapping out some meat for beans or lentils at your dishes. And no need to invent the wheel, right? You can enjoy the meals that you have, but maybe make them meatless. For example, if you're making tacos, maybe doing a black bean taco instead of a beef taco, or doing half beef, half black beans. Or choosing to do, a meatless day for the week. Try expanding your palate too. Many other cuisines and countries have naturally vegetarian or plant-forward dishes, such as Indian, Thai, Japanese, Ethiopian. So look for inspiration outside of the typical American cuisine. For a number of folks out there, people who like to track things, try and aim to have 30 different plants in the week. This might sound like a big number, but it's not as hard as it seems. This helps get variety of colors and fibers, and it's the number that's been associated with the most optimal gut health. If you're trying to cut out more processed food, try bringing your lunch to work from home instead of grabbing something outside very quickly. The more that we can cook from home, the more control we have over what we put into our bodies and what we put into our meals. Skip the sugary drinks and try a flavored water or sparkling water infused with fruit or herbs. This is one of the easiest ways to cut out on added sugar in our diet. And most importantly, remember, perfection is not the goal, right? So I always like to remind folks that all foods can fit into a healthy dietary pattern. Breaking this all or nothing mentality that I think a lot of us have when it comes to our diet. This really helps us to both enjoy our food and to enjoy good health. So always think about moderation. Happy to answer any questions in the Q&A, but if you have specific questions, I would encourage you to contact our outpatient nutrition services, or you can speak to a dietitian one-on-one. We'd be happy to talk through some of your unique needs and come up with a plan that works for you. But with that said, thank you for having me.
Amazing, healthy, and yummy speech. Thank you so much, Erika. So now we are ready for the question. Our friends and colleagues will help us just to get the question. So while I'm waiting for the question to come to the podium, I have several questions for each speakers, if you mind. So I'm going to start with my question, so taking advantage to be a moderator here. So I will start with Dr. Ali Jones. Okay, so Dr. Ali Jones, I'm talking about the breast cancer. So as a primary care, I have heard many patients coming to me and I said, okay, Dr. Rezaeian, I do not want to do breast cancer screening by mammogram. There is a radiation, and I want to do like a thermography, which is checking which part of my breast has more, some change in the temperature, and then that's the new way. Or sometimes I was saying, okay, I would like to have MRI for my mammogram, and what would you recommend for the? Thank you so much. What would you recommend for those type of the non-recommended or not the guidelines recommended breast cancer screening?
Well, I think often when people don't want to go forward and have a mammogram, there are a lot of misconceptions about mammogram and radiation exposure. So I think a lot of times providing information to patients will help them make a better decision for themselves. So that's number one. Number two, I do have patients who are absolutely resistant to mammograms, and I like to try to meet people after I have talked to them and educated them and they still are sort of stuck in their decision. I want to meet people where they are. Mm-hmm. So if someone feels more comfortable with a certain modality, I think that's an open door, and mm-hmm. I say, okay, let's do what you want to do. Mm-hmm. But a lot of times education can really ease people into doing screening.
Absolutely.
Yeah.
Okay. So, and I have few patients here now being kind of getting spoiled with all those electronic health record. I have a difficulty reading the handwriting of the people. So let me try to read. So there is a question for Dr. Bhayani. They said, how much of the colon cancer can be inspected via the colonoscopy? Does any test also, okay, so is there any test can also prevent or detect the small intestine cancer?
So 2 questions. One is how much of the colon can be inspected? So a good colonoscopy, a complete colonoscopy looks at the entirety of the colon. That is the gold standard, and if the GI doctors cannot do that for some reason, they will either bring you back to do it again or do it more frequently or get additional testing. But the entirety of the colon, the large intestine, should be seen on a colonoscopy. Small intestine cancer is quite uncommon, and so we do not do screening. We don't go looking for it because it's very rare. If somebody has signs of small intestinal cancer, there is a way that we do not offer here at Torrance Memorial. There is a way to get a scope there, but we don't offer that here. Alternatively, it's usually diagnosed by a camera in a capsule that you swallow that travels through you that takes pictures along the way. So those would be the ways to look for a small intestinal cancer.
Thank you so much, Dr. Bhayani. The next question is for Dr. Ali Jones. The audience asks, please speak on the link between the breast cancer and drinking, increased risk factor for the cancer survivor if they drink. So the question probably is it safe for the cancer survivor to drink, and is there any relationship or links between drinking alcohol and breast cancer?
So there are definitely Drinking alcohol in excess is a risk factor for an increase of breast cancer, but hearkening back to what Erica talked about, drinking in moderation is allowable, but moderation is different between men and women, and one drink, going toward no drinks is the ideal, but having one alcoholic beverage per day is considered moderation. So certainly if you have a diagnosis of cancer or prior cancer, you can drink, but again, in very, very small quantities.
Okay, so technically, less is better.
Yeah, definitely.
Okay, thank you so much, Dr. Ali Jones. Next question is for Dr. Horodner. Dr. Horodner, they're asking if the smoking cessation decreasing over the time also apply for the second-hand smoker. I think the question is if smoke cessation over the time, as much as we are getting away or further from the smoking cessation date, the risk of the cancer getting less. Does it apply to the second-hand smoker, the same rules?
I think it does. I don't think it's as well studied or documented, but the further you get away from the exposure, I think your risk goes down.
Okay, thank you so much. And the next question actually is kind of a little bit more broad. They said, how do you scan for all the other cancer? Well, cancer other than the breast, lung, and colon, and CT scan, MRI, or ultrasound. So any of you are volunteer to answer this question?
We don't routinely screen for every cancer because there's not enough population data that those cancers are at high enough risk for the average person to screen for. Cervical cancer, we do pap smears, but other cancers would be more specific if there's a strong family history, if there's some type of genetic predisposition. Sometimes I send patients over to see Dr. Bhayani that have pancreatic cancer history in their family and have a genetic mutation, and we may do ERCP procedures to look at the pancreas, endoscopic procedures, we might do MRI scans, but it really depends on the type of cancer and the patient's risk factors.
Yeah, just to piggyback on that, Torrance Memorial has the only program in the South Bay, and actually one of the few in the entirety of LA County, where we screen for pancreatic cancers in high-risk patients. So patients who have BRCA1 and BRCA2 mutations, which typically, people are most concerned about breast cancer and ovarian and endometrial cancer, which is absolutely appropriate, also carry a very high risk, much higher than average risk of pancreatic cancer. And so we have a screening program that I'm the leader on for those people. So that's something that is very unique to our population down here that we're very fortunate to have.
So I have a question here. So from the physician standpoint, who will be the people that we are running those ERCP cancer markers for them?
Yeah, so the blood testing cancer markers is oftentimes not, at least with the exception of PSA and maybe a few others, it is not overall part of the screening process. We use colonoscopy, we use mammogram, we use low-dose screening lung CTs. For the pancreas, we use MRI and CT. And again, who does it and how do we do it? I would just say refer to a specialist, whether it's Dr. Ali Jones or myself or Dr. Horodner. We're going to be the go-to people because the subtleties there become very, very complex on who is high risk and how often do you screen and what kind of testing do you need. It becomes very complex.
Thank you so much, Dr. Bhayani. So next question is from Dr. Ali Jones. What causes dense breast and what make the breast dense? Same thing.
So dense breast could be just someone's genetics. They can just have dense breast. Alcohol consumption can actually lead to dense breast. Having no children can be a predisposing factor to having dense breast. But mainly it's something people are just sort of born with. You see dense breasts more in younger women. They have more sort of fibrous tissue to fatty tissue, and yeah.
Thank you so much, doctor. And the next question is for Dr. Horodner. How many puff of the vape is equal to a cigarette, and how much nicotine is in a vape? I think it really depends, but.
Yeah, I think it does. It depends on the device that you use. Every product is different. It's not really clear. Some of them are regulated and are FDA approved. Many are not. So I think it depends on, many of these devices have nicotine, a few don't. But how many puffs is equivalent to a cigarette? I think we really don't understand that. I think that there's chemical carcinogens in the vapor, but it's not nearly the same risk as tobacco smoke. So you'd have to probably vape quite a bit more to get the equivalent of a cigarette.
Thank you so much, Dr. Horodner. The next question is for Erika. I recently saw an article that said that the cooking utensils made from the black plastic will emit carcinogen when heated. Does it make sense?
Like heated plastic?
Yeah,
Okay.
yeah. The black plastic, if they are using those, I think probably just putting in the microwave those utensils that has the black color. Yeah.
Okay. Black plastic specifically. I think all plastic we probably shouldn't be microwaving. I don't know if any of you guys know the statistics there, but yeah, I'm not sure. But yeah, I probably, yeah, that's a good question.
And the next question is for Dr. Bhayani. Does Medicare cover stool DNA test?
Dr. Horodner might know. I do not know the answer if Medicare covers that.
I think it depends on the test, but my experience has been they do cover a lot of these tests, which confuses people. And I think it makes it problematic because people think because the insurance covers it, that it's a good idea, which, as Dr. Bhayani said, it's really not.
Yeah, and then my personal experience as a person that kind of, ordering those screening tests. Usually, yes, actually, sometimes I'm ordering the colonoscopy for the patient, but patient come to my office, my insurance send me the Cologuard, which I agree 100% with Dr. Bhayani that I personally prefer colonoscopy. And just a quick comments here, because many times we are asking if the patient has the higher risk, higher than average risk for the colon cancer screening, because if somebody has one of those criteria, we need to proceed with the colonoscopy. And one of those criteria, if patient has a personal or family history of colon cancer or colon polyps. The problem is many of the people, they do not have, if they have a family history of colon polyp, if the family not here in United States and then the other country not proceeding with the screening that we are doing here. So not knowing that, they put them at a risk. So we are assuming, they are saying no because they never been tested. The other family member never been tested. So technically we are missing some people that they are high risk, but they don't know they are high risk. So I agree with Dr. Bhayani. I would prefer to find any reason to do the colonoscopy for my patient, I would do that. But then answering the question, yes, Medicare usually pay for that. Most of the Medicare plans. Okay, so next question, actually, I'm going to ask one of my questions from Erika. Erika, could you please repeat again those kind of amount of the alcohol that is, allowed? So how much of the wine, how much of the, hard drink, those things?
Yeah, so one drink is considered 12 ounces of beer, 5 ounces of wine, or 1.5 ounces of any hard liquor.
Thank you so much. I think that's very important approaching the holiday seasons. Please be mindful of how much you drink, not only because we want to avoid the drinking and driving and all of those issues, because of your health. So The next question is, if I heard correctly, Dr. Horodner mentioned there is a type of the cancer that can be treated with the pills. What type of the pills and how they work, and then why don't they work with other type of cancer? Several questions, Dr. Horodner.
Sure. No, those are all good questions. I think lung cancer, I could show you a chart. It's really exploded in the last 15 years. They figured out how many different mutations, what we call driver mutations, cause lung cancer. And in many of these situations, it's not tobacco that triggers this. So the most common mutation is called EGFR, or epidermal growth factor receptor. And it was found early in Japanese or Asian younger women that have been non-smokers. They kind of saw it there, and they found that this mutation was prevalent. And drug companies developed a pill that basically is sort of like a lock and a key. The pill kind of gets in and turns off the EGFR protein and causes the cancer to shrink. And it's quite effective, much more effective than chemotherapy and much less toxic. And there are other driver mutations like ALK or ALK, and there's a whole laundry list of rarer types. But these drugs, they were studied in patients that don't have the mutation, and while there might have been a little bit of off-target, as we call it, effect, most patients don't respond because they don't have the specific target. And these drugs, like EGFR inhibitors, are now, they were first approved in the metastatic lung cancer setting, but now they're actually approved in the non-metastatic setting. We can give patients that have curable lung cancer, that have surgery, that have an EGFR mutation, they can take this pill. The most common one on the market is Tagrisso or osimertinib for 3 years. And there's an ALK inhibitor that's also on the market for early stage lung cancer after surgery. So it's really changing how we treat people. People are having much better outcomes in the advanced and the local setting.
Thank you so much, Dr. Horodner. Dr. Bhayani, I have a question for you. So if the patient comes with a colon polyp at age of, for example, 74, and obviously recommended to come back in 5 years or 3 years based on the type of the polyp, and then patient comes to me and say, you know, Dr. Rezaeian, after age of 75, I know that they're not recommending colonoscopy. What would you say? So I'm obviously telling the patient that do that because you already have a colon polyp. You might have the cancer within next 3, 4, 5 years that they recommended. So could you please educate us on that?
Yeah, again, I can't emphasize this enough. The need for colonoscopy is based on what's your chance of something else killing you first. That's really what it comes down to. On an individual basis, if you're sitting down from your doctor and if you've got other significant medical problems that are a much bigger problem, then you don't need a colonoscopy. But if you're healthy and functional and living your life and you've got a decent life expectancy, 5 to 10 years, and it's your time to go and look for something, if you're average risk or high risk or above average risk, then a colonoscopy is worthwhile. It really is about what is going to get you first.
Thank you so much. Really appreciate Dr. Bhayani. The next question is for Rika, and then I think we can finish before 8:30. What food should I eat if I have a cancer?
That's a really good question. So nutrition for cancer prevention is a little bit different than what we're talking about for nutrition during cancer, specifically if you're undergoing cancer treatment, right? Chemotherapy or radiation therapy. So all the things that we talked about were for prevention, right? A plant-based diet, less processed food, less red meat. But when we're going through therapy, there's a shift that happens, right? So we're trying to focus on a lot of symptom management, right? Because chemotherapy, radiation therapy can have a lot of side effects that inhibit your ability to eat, right? Decreased appetite. We want to be preventing weight loss as much as possible. We know that that is a very common side effect of a lot of chemos and radiation. So we know that people who are better nourished just tolerate their treatment better. So the priority is about optimizing calories and protein, right? Making sure that we're maintaining our weight, having enough energy so that we can tolerate the rest of our treatments. So I always say there are no specific foods to 100% restrict during treatment either. And there are no magic foods or no cures either. So again, more balance, but not too restrictive, right? If a milkshake is the only thing that sounds good to you in the moment, a milkshake is better than nothing. So yeah, there is a shift that happens. It's a good question.
Thank you so much. But before we finish here, and I just want to mention something is area of my interest and cardiometabolic, cardiovascular disease prevention, which is the area of my interest that those people that they know me. So we all talk about the cancer and then thanks to all the speakers, but you may know that the cardiovascular disease is the #1 killer of the human. All the cancers we talk about is killing the people less than cardiovascular disease. Please, please make sure you are going to see your primary care doctor not only for doing all those preventative measures through your annual physical. So make sure at the time that your birthday comes, you're already done with your annual physical with your primary care. Don't make an appointment to follow-up appointment for the lab result, those things. You want to say, I want a preventative appointment, or I want my annual physical with my doctor to discuss all the screenings. And they're not only talking about all those cancer screening, also they will discuss about the cardiovascular risk factors screening, including your blood pressure, including your cholesterol, including your diabetes, family history, personal history. If you had, the women had the adverse outcome of the pregnancy, high blood pressure during the pregnancy, those type of things, increased risk of the cardiovascular disease. Please don't underestimate the cardiovascular disease when we are paying all the attention which actually deserve to be paid to the cancer screening and treatment. I wish you a very good evening, and thank you so much again to all the amazing doctors and speakers. We are so blessed to have you here.